Hey there, CyberMDs, and welcome back to another lecture in our USMLE Step 2 Cardiology series. In this lecture, we're going to be covering heart failure, so please make sure to like, comment, and or subscribe so that we can continue to provide free medical education resources for students all around the world. Let's dive right in. On this slide, I've merely presented an overview of the lecture so that you can get an idea for the roadmap for this lecture. We're going to discuss everything from the pathology to risk factors, all the way through to the treatment of both acute and chronic heart failure. And acute meaning acute exacerbation of that chronic disease. So without further ado, let's get started talking about some of the pathology in heart failure. So heart failure in its simplest terms is the heart's inability to adequately pump blood to meet the body's needs. This inadequacy can rise basically from two primary mechanisms. It's either going to be a failure of flow or a failure of the heart to fill. So heart failure is failure of flow or filling. A failure of flow, or systolic failure, is going to refer to the heart's inability to create the proper or adequate amount of squeeze or to contract effectively. It's not doing those things, and that's going to lead to that reduced blood flow out of the heart. This reduced flow, specifically a reduced ejection fraction, or EF, is classified as either, sometimes it's referred to as HFrEF, HFrEF, which stands for heart failure with reduced ejection fraction, or it can be HFmrEF, which is heart failure with mid-range ejection fraction. For heart failure with reduced ejection fraction, again sometimes called HFrEF, is when the ejection fraction is actually going to be less than 40%. That mid-range reduced ejection fraction is going to be heart failure with an EF between 40 and 50%. Now, let's talk about some of the causes of systolic or flow failure. So this reduced ejection fraction failure. Causes of this poor squeeze is what it's often referred to. So causes of poor squeeze can include tissue ischemia or infarction, maybe hypertension or substance abuse. Ischemia and infarction can damage that myocardium itself, which is going to result in that poor squeeze because the heart itself is damaged and or dead. The chronic strain of hypertension can also affect the heart's ability to pump, and substance abuse, especially alcohol, is commonly related with weakening of the musculature of the heart itself. Remember, though, that a poor pathway, so it's important to remember, we've talked a lot about flow, so generating the proper flow, the proper squeeze is what we've been discussing so far, but that the pathway can be important too and can be a cause of systolic failure. So a poor pathway, often referring to regurgitation. So when the valves of the heart don't close properly and you get backwards flow of blood, that can actually lead to systolic dysfunction over time as well. So we've covered failure of flow, we talked about tissue ischemia, poor squeeze, and a poor pathway, and now we're going to cover diastolic dysfunction, or failure to fill properly. And that's going to be due to maybe like a stiffening or a restrictive pattern of the musculature of the heart. And often they have a preserved ejection fraction, so this is going to be HFpEF, sometimes referred to as HFpEF, or heart failure with preserved ejection fraction, where their ejection fraction is actually over 50%. And that restrictive pattern of diastolic dysfunction can either be caused by, again, that stiffness, or can be caused by external compression as well. So by myocardial stiffness, what I'm actually talking about is the heart muscle itself becomes less flexible, which is going to prevent it from fully relaxing and expanding, allowing it to fill as it should. So you can no longer relax and expand and fill those ventricles the way you should be able to. And that's going to be caused by maybe fibrosis or scarring of that heart tissue. So myocardial infarction, if it scars really bad, can actually cause this restrictive pattern as well, the stiffening of the heart. It may be due to hypertrophic cardiomyopathy as well. With all that heart musculature, the heart chamber is actually reduced in size, and so you get a preserved ejection fraction, but it's actually not pushing out very much blood because the size of the chamber has been reduced so significantly. And because there's so much muscle there, all of that muscle has a hard time relaxing, and so you get this diastolic dysfunction as well. And then I mentioned external compression as a sign or a possible etiology of heart failure. So cardiac tamponade could actually be considered heart failure. So you have this fluid accumulation around the heart, which is actually leading to compression, external compression, which is going to make it impossible to open up and fill during diastole. So you can see that pretty well on ultrasound with a really large pleural effusion and vital signs that reflect that tamponade physiology. Other ultrasound findings that are pretty commonly referred to are called right atrial systolic collapse. And so this is also possible you can also look for right ventricular diastolic collapse. But remember that in systole, the ventricles, so while your ventricles are squeezing, your atria should be filling. And so if the really low pressure of the right atrium is collapsing while the ventricles are squeezing, so it's collapsing as it should be filling, then it's likely that there's going to be this compression around the heart. And then similarly, if the low pressure of the right ventricle isn't filling during ventricular diastole and instead it's collapsing, that also could be indicative of cardiac tamponade. And then another cause of external compression is going to be pericarditis, where you have this inflammation of the pericardium, and that's going to cause some restriction and some diastolic dysfunction, as that inflammation is actually causing the heart to be kind of stiff and causing this restrictive pattern as well. So now that we've covered kind of the pathology of heart failure, I have a couple of diagrams to help you remember that there is left heart failure and there's also right heart failure. And so remember that in left heart failure, here on this diagram, you can see that I have the left heart red, oxygenated. If that left ventricle fails, you have atria on top, ventricle on bottom. If that ventricle fails, that blood flow is immediately going to back up into your pulmonary system. And then on the next slide, we have right ventricular and isolated right ventricular failure on this slide, which means you're going to back up immediately into systemic circulation. But remember that the most common cause of right heart failure is going to be left heart failure. So in most cases, you either have a left heart failure pattern or you have this left heart failure pattern with concomitant right heart failure pattern as well. And so you'll start seeing systemic signs, which we'll talk about shortly. But before we dive too much into the clinical presentation, let's take a second and to review some very high-yield risk factors to look for in your patients, both clinically as well as on your tests, your exams, your STEP exam, to make sure that you're thinking about these risk factors for heart failure as you're assessing your patients and taking your exams. All right, so remember we always split our risk factors into modifiable and non-modifiable risk factors. And so our modifiable risk factors here are going to be this high cholesterol. Remember that can lead to atherosclerosis, and that in turn can narrow the arteries, harden the arteries, make the heart work a lot harder, and potentially lead to heart failure. Remember that hypertension forces the heart to work harder than it should, and over time that can weaken the heart muscle. Smoking can damage the heart and the blood vessels, leading to the buildup of those fatty plaques similar to high cholesterol, and that can increase the risk of, atherosclerotic processes and subsequent heart failure. Remember that diabetes, especially if it's really poorly managed, that can actually increase your risk of heart failure. Obesity is going to put additional strain on the heart, and it's often going to come with other risk factors like the high cholesterol and the hypertension and the diabetes. So obesity itself is going to be a risk factor. And then sedentary lifestyle, which often comes with obesity, that lack of physical activity can lead to other heart-related issues, and it can lead to obesity again, which is one of these modifiable risk factors. And so if you regularly exercise, that's going to strengthen your heart, but if you lead a sedentary lifestyle, that can lead to an increased risk of heart failure. And so those are the big modifiable risk factors. Now, the non-modifiable risk factors include your sex, which both men and women can develop heart failure. Men are typically at a higher risk for this. You'll see more men with heart failure probably than you do females in your clinical practice. Race is going to be another non-modifiable risk factor. Certain racial and ethnic groups have increased risk, such as African Americans. That ethnic population is at a increased risk for heart failure, as well as Native American Indians. That's also an ethnic population, a race that is at an increased risk for heart failure. Remember that family history is also a non-modifiable risk factor. So family history of any heart disease can increase your patient's risk for heart failure. And then lastly, you have increasing age. So as we increase in age, all of us, male, female, doesn't matter our race or ethnicity, as we all age, we are at an increased risk for developing heart failure. That's something we can't reverse and that we can't modify, and so that falls under our non-modifiable risk factors. So now that we've covered risk factors, let's talk a little bit about the common symptoms that you will encounter when you're taking a HPI on a patient with heart failure. So the number one thing is going to be shortness of breath. Now, remember, we talked about the most common cause of right heart failure is left heart failure. And when you have left heart failure, the first place that fluid is going to back up into is going to be the lungs, right? And so if you have this fluid spacing out into the lungs, you're taking up that surface area and that contact space where you should be oxygenating and having oxygen cross over the alveoli, getting into your bloodstream. And so your patients are going to be short of breath. That's going to be like the number one chief complaint of patients who come in with heart failure. So this can be exertional, it can occur with activity, but if the heart failure is very bad, it can also be occurring at rest. Be sure to ask your patients about orthopnea. Does the patient experience difficulty breathing or shortness of breath whenever they lie flat? Maybe they wake up at night, paroxysmal nocturnal dyspnea. They wake up at night feeling like they're drowning or feeling short of breath. Another common complaint, obviously less common than shortness of breath, but still can happen, is chest pain. So not all heart failure patients will experience chest pain, but it is a significant symptom to think about and to ask about, and it can be indicative of ischemia as an underlying etiology for that patient's heart failure. You can also ask about palpitations. Patients might describe this as a feeling like their heart is racing or skipping beats, and that can be due to an arrhythmia. You can actually have tachycardia-induced heart failure, and so that's something to think about. You can ask about fatigue. Fatigue is the next one on our list. It's a pretty non-specific chief complaint and is a pretty non-specific symptom overall if you're catching that during maybe a review of symptoms. But it is very common in heart failure patients. So they have this decreased cardiac output, and the muscles and organs aren't receiving enough oxygen to really make ATP. Remember, oxygen is that terminal electron receptor. So they're not receiving enough oxygen to make ATP, and so they get this just generalized global fatigue. A lot of these patients also experience anxiety. Imagine being short of breath, having chest pain, feeling tired all the time. Those are very distressing symptoms to be experiencing, especially all at once if the heart failure is really bad. And so the nature of their symptoms is distressing, and that can lead to anxiety itself. Think about diaphoresis. It can be a sign of the body's increased workload, that the body's trying to compensate for this lack of oxygen. It's trying to compensate for this lack of ejection fraction, this really reduced ejection fraction. So it has all these compensatory mechanisms going on to try and combat that, and that itself is stressful on the body and can lead to excessive sweating, this diaphoretic presentation. And finally, poor nutrition. Some patients actually experience a loss of appetite or nausea due to congestion all the way into the gastrointestinal system. They have essentially like fluid backing up into their GI system. And so that can actually cause them to have poor appetite, and then they have really poor overall nutrition. So make sure you assess that when you have a patient with heart failure. Make sure that it's not so bad that they're actually having this GI buildup of fluid leading to this nausea, leading to this poor appetite, leading to subsequent poor nutrition. That's something you really want to address in these patients. All right, so we've taken our history. Now let's talk about some important physical exam findings in patients who have heart failure. Number one is going to be that elevated jugular venous pressure. Remember that the JVP, jugular venous pressure, provides an indirect measurement of the central venous pressure. So in heart failure, due to the inability of the heart to pump blood forward effectively, there's going to be a backflow of blood leading to an elevated JVP. So that's often seen as a distended jugular vein when the patient is at a 45-degree angle. Often if you're trying to assess that, you'll have the patient look the other way. You'll see the JVP while the patient's at a 45-degree angle. You'll check for JVP and you can see this distended neck vein. And oftentimes it's actually, when it's really bad, it's really prominent and you can see, and it's a very poor prognostic indicator. Number two, you should be checking for pedal edema or any lower extremity edema anywhere, and make sure you know how high up it goes. So if it goes to their knee one day and then you are managing these patients and the next day maybe it's only midway up their shin or up their calf, that's an improvement in their edema. And so that's something you can track on your physical exam that can make a difference, and you are able to say clinically that they appear to be improving. And so remember that pedal edema is a result of fluid accumulation in the interstitial spaces. And so the heart failure, that decreased cardiac output, leads to all this water retention, and that's going to cause that edema to slip out into that interstitial space, that fluid to be in that interstitial space. Number three is going to be a gallop rhythm. So a gallop rhythm is that extra heart sound. Maybe it's an S3, maybe it's an S4. A S3, I believe, in particular, is going to be the classic sign of left ventricular dysfunction and is referred to as the heart failure sound. Number four is hepatojugular reflex. So this is a pretty cool one if you can see it. Obviously, it's cool for you, not cool for your patient. But when you apply pressure over the liver, there's an increase in the JVP. And that's going to be pretty indicative of right heart failure and suggests that the right heart is unable to accommodate the increased venous return. So when you press on the abdomen, typically it's in the patient's right upper quadrant that you would be pressing. You can kind of do this anywhere on the abdomen for the most part, but typically done in the right upper quadrant, again, hepatojugular reflex. But when you do that, you're actually creating an increased venous return in the right atrium. And again, if it can't handle that, you will see an elevated JVP. So that's a pretty cool physical exam technique that you can incorporate into your clinical practice when you're assessing patients for heart failure. Number five is the Kussmaul sign, and that's going to be this paradoxical rise in the JVP during inspiration. And that's going to be seen more in a restrictive pattern. So that's something to look out for if you think the patient maybe has a restrictive or stiffening etiology of their heart failure. Number six is pulsus alternans. This is a good one as well, and that's going to refer to the alternation between strong and weak pulses without a change in the heart rate. And so it's a sign of very severe left ventricular systolic dysfunction, and it indicates a decreased cardiac output. So remember, it's going to be this alternation in strong and weak pulses, no change in the patient's heart rate. Remember that it's not pulsus paradoxus and it's not electrical alternans. Those are two things associated with cardiac tamponade. So pulsus alternans is associated with heart failure, alternating pulsus. So that's kind of how I keep this straight in my head. You have these alternating strong and weak pulses. That's pulsus alternans, and that's going to be due to this left ventricular dysfunction. So remember, your pulse is kind of created by the pressure of your left ventricle creates as it ejects blood out into your systemic circulation. And so this pulsus alternans, this alternating pulse, is due to left ventricular dysfunction, and it's not electrical alternans, and it's not pulsus paradoxus. Those are cardiac tamponade findings. And so test writers can very easily trip you up. Practice questions very easily trip you up with this as a physical exam finding that they're relying on you to know what that is in order for you to properly diagnose the patient and get the question right. And so that's something to really nail down in your head before you go into taking practice exams and doing practice questions. Number 7 is going to be a prominent P2 sound. And the P2 is the second heart sound associated with closure of the pulmonic valve. So if this is accentuated, if it's really loud, it could suggest an increased pulmonary artery pressure, which is going to be commonly seen in pulmonary hypertension. So this is something you might see in a patient who has this isolated right ventricular failure. You could hear a really loud P2 due to their pulmonary hypertension. And then finally, a regurgitation murmur. Again, these are heart murmurs due to backflow of blood across a valve. And in the context of a patient who has heart failure, it's often going to arise due to dilation of the heart chambers. So your valves are coming together like this, and then as this chamber dilates, it pulls it apart, and then you get backwards flow because this has been pulled apart. Your valves have been pulled apart due to that dilation. And so they are unable to close as well as they should, and blood flows backwards across them. So those are all physical exam findings that we can look for in our patients with heart failure, and that can help us clinically to see if they are improving or not, as well as help us to identify possible underlying etiologies for their heart failure. All right, now that we've talked a bit about the physiology and the findings in patients with heart failure, let's talk about how physicians have come to classify these patients based upon the spectrum of their severity of the disease itself. So there are two big classification systems. First is the NYHA, or the New York Heart Association, and that's going to be what the vast majority of physicians will use when discussing patients with heart failure. And that's assuming they have a diagnosis of heart failure. The ACC, American College of Cardiology, and AHA, American Heart Association classification system, is often used as an adjunct to help identify patients without a heart failure diagnosis, but who are at a high risk for developing the condition. So first, let's discuss the NYHA, again, New York Heart Association Heart Failure Classification System. It's going to be 1, 2, 3, and 4, with 1 being the least serious and 4 being the most serious. So in class 1, patients are going to have no limitations on their physical activity. They don't experience any symptoms, even with regular levels of exertion. And essentially their heart failure does not interfere with their daily life. Now, as we progress to class 2 of NYHA, these patients have slight limitations on physical activity. And so they're going to be comfortable at rest, and they're going to engage in normal physical activity. But when they engage in this normal physical activity, sometimes that is going to lead to symptoms. And this might mean that a simple task, like walking up a flight of stairs, could cause them to have shortness of breath or fatigue. We take that a step further and we go to class 3. Patients in that category have significant limitations on physical activity. So class 1, no limitations. Class 2, a little bit of limitation. Class 3, significant limitations to their physical activity. Again, these patients can remain comfortable at rest, but even less than normal activity, so really easy things, will cause symptoms. So, for instance, maybe walking a short distance on flat ground, not climbing stairs, but walking a short distance on flat ground can, or even maybe dressing themselves, can lead to symptoms. So, comfortable at rest, but significantly limited when it comes to physical activity. So again, 1, no limits. 2, some limits. 3, a lot of limits at physical activity. But remember, all these people are comfortable at rest. Then we get to class 4. That's the most severe, and patients will experience symptoms at rest. Any form of physical activity is going to exacerbate their symptoms, and these patients are often going to require very strict medical management and are often going to be candidates for more advanced therapies and interventions, which we're going to discuss later. So we move from NYHA, which is kind of all about the limitations that the patient has. No limits, a little bit of limits, a lot of limits, and then uncomfortable at rest. And then we move from there and we kind of add this class structure to where in class A, you're just identifying people at risk. And that's kind of what the ACC and AHA classification system is all about, is adding this patient group, this patient population where they're at risk for heart failure, and we want to identify them so that we can get ahead of that. So stage A for them, this is going to be A, B, C, D, A being the people who are at risk but don't have a diagnosis yet. So stage A, at risk, no diagnosis, no structural disease or symptoms, but they have risk factors: hypertension, diabetes, family history of heart failure. We move forward to stage B. They have structural or functional heart disease, but they're still asymptomatic. This could mean that they have LV hypertrophy or they have a reduced ejection fraction, but they haven't started to develop any symptoms. So at risk, and then have this structural heart disease but are asymptomatic. And then in stage C, these patients have either current or have had in the past symptoms of heart failure. They might even have episodes of shortness of breath, fatigue, fluid retention that are all going to be indicative of heart failure. And you take that one step further, you get to stage D, the advanced stage, and these are patients that have symptoms that interfere with their activities of daily living, or their ADLs. You'll often hear activities of daily living referred to or abbreviated as ADLs clinically. And that's going to lead to repeated hospitalizations. They're going to require that specialized care, those other interventions that we're going to talk about, these advanced treatments, maybe like heart transplant or some sort of mechanical circulation device, such as an LVAD, which we'll talk about. And so to summarize this slide, in clinical practice, you're going to see a lot of patients on the NYHA scale, but the ACC and AHA scale can help you to identify at-risk patients. And so you'll come across both of these likely when you're doing chart reviews on your family medicine, your emergency rotations, your internal medicine. If you're chart reviewing a patient, you'll see these NYHA and ACC-AHA classifications, and you'll know, generally speaking, how bad this patient's heart failure normally is. All right, so let's talk about making the diagnosis of heart failure. Essentially, many of these patients are going to show up in the emergency department first with an exacerbation, and then they may or may not begin to receive the appropriate care outpatient follow-up. Because they may show up in the emergency department, let's talk about acute exacerbations first, what gets done in the emergency department, or what should be done in the emergency department, and then how the disease is managed from a chronic standpoint. First and foremost, the diagnosis of heart failure is going to be a clinical diagnosis. This means that the diagnosis is primarily based on the patient's symptoms. Physical exam findings, medical history, these are all things that can help support your clinical diagnosis, but it's not going to rely solely on a single lab or a single test or imaging result. Now, before we dive into specific tests, it's crucial to assess the patient's cardiopulmonary and hemodynamic status, i.e., are they stable? Is the patient stable? When you see them, are you in HPI mode? Are you talking to them, taking a history? Or should you swap to ABC mode, airway, breathing, circulation? So are they stable? That's your first thing. Your second step in the emergency department is likely going to be to rule out any kind of ischemic etiology, rule out any kind of myocardial infarction that's going on. So you're going to want to get an EKG, a troponin, which might suggest this very recent or ongoing current myocardial infarction. You can also adjust your clinical suspicions for an acute exacerbation, again, by utilizing your history-taking skills, your physical exam skills, your review of symptoms. You can place other labs and orders, and you typically are going to. Those are going to include things like a BNP, things like a chest x-ray to visualize the heart's size, maybe get a look at some pulmonary congestion. You're often going to do an echo, a point-of-care ultrasound, transthoracic echo in the emergency department. That's going to provide you, hopefully, with a detailed view of the heart structure and function. How good is their squeeze is often what we would talk about in the emergency department. See if there's any large structural abnormalities that could be contributing to that. You can also do a lung ultrasound, which may help you to identify pulmonary edema. You can look at pulse ox. You're going to want to look at pulse ox to make sure they're stable, measure their oxygen saturation. Do they need oxygen supplementally? You're going to want to get a CBC because that's going to give you an overview of their hematologic status. Are they anemic? Maybe that's contributing to their shortness of breath that they likely have. You can probably get a CMP, maybe a MAG level and FOS level, assess their overall metabolic status, their electrolyte balance, make sure they don't have any other funky things going on. And then another thing you can get is actually a lactic acid level, which may be especially important because, again, we have this failure of flow, this failure of forward perfusion in the end. And so if we're not perfusing forward, we could get some ischemia at some other organs, maybe like the kidneys or maybe any other organs. It could be any of them, your GI tract, your kidneys, and that's going to cause end organ damage, and then your lactic acid level is going to go up in your blood because of that ischemia, because of that damage. And so that's something you can look for. Is there other damage going on? And then once you've made this diagnosis, this clinical diagnosis, you've gotten this huge picture using your HPI, your labs, your review of symptoms, your physical exam, all of these things, your imaging. You've made this diagnosis. This person's having an acute exacerbation of heart failure. You really need to find the etiology. And it's not enough to say, remember, it's not enough to say this patient has heart failure. You really need to find why they have heart failure. And so a useful mnemonic is the mnemonic CHAMP-IT, or CHAMP-IT, and that's going to stand, the C stands for COPD. Patients who have COPD can also have heart failure at the same time, and an exacerbation of COPD can lead to an exacerbation of the heart failure itself. The H is going to stand for hypertensive emergency. The A is going to be arrhythmias, or ACS, so remember, we're ruling out a myocardial infarction. The M is going to stand for mechanical issues. Maybe they have HOCM, maybe they have pulmonary embolism. The I is going to stand for infection, so patients with heart failure who become very septic can actually have an exacerbation of their heart failure and may even come in shock. And then lastly, the T can stand for toxins. Maybe alcohol or other drug use can cause an exacerbation of their heart failure. Maybe trauma. Maybe they were in a car accident and this trauma has caused an exacerbation of their heart failure that was already there. And then also, I always use thyroid in this mnemonic, and that thyroid's generally going to remind me of underlying endocrine issues that could eventually cause an exacerbation of heart failure if it was bad enough. And then I just want to have a little bit of a sidebar here to remember that both heart failure and COPD, acute exacerbations of those conditions, can present with shortness of breath, but their underlying causes, their underlying etiologies, their treatments, their prognosis is all going to be very different from each other. So it's essential to differentiate between the two so that you can provide the best care and the most appropriate care to your patients. Remember, the easiest way to discern between the two is that an exacerbation of heart failure typically is going to reveal very wet lung sounds. There's going to be fluid buildup in the heart, whereas an exacerbation of COPD will tend to have more wheezing and coarse breath sounds, maybe prolonged expiration times on your physical exam. So really use your physical exam findings, both clinically and on the test, to differentiate between an exacerbation of heart failure and an exacerbation of COPD. Your test writers are very often going to make you compare and contrast the two, and then the physical exam is going to, particularly the pulmonary physical exam, is going to be very telling on which one of the two it actually is. And that's going to help you make the right choice clinically, help you make the right choice on the test. And again, this is all assuming that there is no isolated right heart failure. This is assuming that you have a left heart failure with fluid backing up into the lungs versus an exacerbation of COPD where there's not really a fluid overload issue. So again, use those physical exam skills both in real time and on your exams to come to the right conclusion for your patients. So we've diagnosed an acute exacerbation of heart failure. The question now becomes, what do we want to do about it? A classic or traditional teaching is to treat the patient, with LMNOP, which stands for Lasix, morphine, nitro, maybe nitrates or nitroglycerin, oxygen, and patient positioning. However, before we move on, let's dive into each one of these just a little bit further. Lasix is going to play a very pivotal role in the management of acute heart failure exacerbations. It helps by reducing the preload, by promoting the excretion of salts, of water, and thereby alleviating those symptoms of congestion, such as shortness of breath, such as edema. It's essential to titrate that dose based on the patient's volume status, their renal function, and additionally, with regards to clinical practice, this is something that will come up that hopefully someone teaches you. If not, I'm teaching you now. It's important to remember that Lasix is in the body for 6 to 8 hours, and therefore you should time your dosing accordingly. So Lasix works for about 6 hours. Now, number 2, morphine. It's kind of a controversial agent to use. Historically, it was used in patients with acute exacerbations of heart failure because it had some vasodilatory effect and it had some anxiolytic effects. However, some recent evidence actually suggests that it may be associated with some adverse outcomes. And so if it's used, you should really be monitoring the patient closely. However, this is going to probably vary by provider preference. So I will talk in a second, but I think there's a better thing we can use for M. So I think it should be Lasix, and then the M should stand for monitoring, because we want to monitor the patient's volume status. We want to regularly assess for signs of fluid overload, that JVD, that edema, see if it's improving, because that can really provide some valuable insights. I also want to monitor the patient's oxygen. Do they need continuous pulse ox, but do they need supplemental oxygen, nasal cannula, high flow, BiPAP? Do they need those things? I also want to monitor and have them on strict I's and O's, their fluid intake, their urine output, because monitoring that fluid balance is going to be really essential to kind of tuning that patient up from the emergency department to the internal medicine doctors who are probably going to manage that moving forward. So having that data early on is really important. Additionally, we can monitor the patient's daily weight. A sudden spike in weight can be an early sign of continued fluid retention, and we're trying to bring fluid off of these patients. So thinking about monitoring instead of morphine as the M can be very useful. Now let's talk about these nitro drugs, the nitrates. So those nitrates are going to be potent vasodilators that can reduce both preload and afterload. The 2 commonly used agents are going to be nitroprusside, which is going to be this direct vasodilator that acts both on arteries and on veins, so it's going to alleviate both afterload and preload respectively. It's often going to be used when hypertensive emergency is the etiology of the patient's exacerbation of heart failure. Nitroglycerin, on the other hand, is going to act primarily on the venous system, and so it's going to simply reduce preload, and it's often going to be beneficial in patients with ischemic etiologies. It is somewhat important to note that a really high dose of nitroglycerin can actually have some vasodilatory effect on the arterial side, but it's going to vary a lot by patient, and so I think it's unlikely that you would be tested over that, and I think it's easiest to just remember that nitroprusside for hypertensive etiologies and nitroglycerin for ischemic etiologies. Just remember that inferior infarct of myocardial tissue, that nitroglycerin is actually going to be contraindicated due to the heart becoming preload dependent. So just something to keep in the back of your mind to try and help you connect some of these dots clinically. Number 5, that O, oxygen. Again, supplemental oxygen. Do they need nasal cannula? How many liters? Do they need high flow? Do they need BiPAP? Make sure that oxygen saturation stays up, and that will help you to improve their clinical status and their shortness of breath, their symptoms. Number 6, patient positioning. Position them in an upright position with their head up above their heart. Don't lie them flat. Remember, these patients often have orthopnea and paroxysmal nocturnal dyspnea. So sit them up. This position is going to facilitate better breathing. It's going to alleviate a lot of their symptoms. And then number 7, this isn't a part of LMNOP, but you can go ahead and throw P on if you want for this. A second P, prophylaxis, thromboembolism prophylaxis. We're not moving blood forward very well in these patients, so they are at an increased risk for thromboembolism. So make sure we admit these patients with prophylactic measures for thromboembolism. Those are all things to think about, maybe like a low molecular weight heparin. You should probably give them compression devices on their legs, anything to reduce the risk of thromboembolism. These patients you should at least think about providing those patients with such interventions. Now that we've managed the acute exacerbation, let's talk about managing the chronic disease. And for me, I always remembered the ABDs, or ABD apostrophe S, of managing chronic heart failure. So this is often referred to as guideline-directed medical therapy, or GDMT. This changes every now and again in small, nuanced ways, but I'm trying to give you the big picture today. So let's talk about the A's. These are the angiotensin receptor neprilysin inhibitors, your ACE inhibitors, your angiotensin receptor blockers. So this is going to be first line. It's going to help with some of the hypertension issues, some of the preload or afterload issues, and it's also going to help prevent cardiac remodeling. Frequently, it's going to be this combination of a ARNI and an ACE inhibitor, and it's been shown very well in the literature that combination in particular has significant benefits in reducing heart failure related morbidity and mortality. So that's typically going to be your first line, this ARNI ACI combination. Number 2, second line that you're going to add, if that's not enough, is going to be beta blockers. So remember, beta blockers are going to reduce heart rate and they're going to reduce heart or blood pressure. And they're going to play a pivotal role, again, reducing that workload. So if you reduce the rate, you reduce the pressure, you're reducing overall workload on the heart itself. So that's going to improve survival in our heart failure patients. A lot of the commonly used ones are going to be your metoprolol, carvedilol. Those are going to be pretty common meds you see used as the beta blocker in heart failure patients. Number 3, so we did A, we did B, now we're doing D, the ABDs of managing chronic heart failure. D is going to be diuretics, and typically you're going to have a preference for the mineralocorticoid receptor antagonists, so your eplerenone and your spironolactone. Eplerenone is going to be preferred, however, it's typically more expensive, so spironolactone is acceptable and is often used to reduce the cost burden to the patient. And finally, number 4, S-GLUT2 inhibitors. So ABD apostrophe S, the ABDs S-GLUT2 inhibitors. Remember, these are sodium glucose cotransporter 2 inhibitors. And remember, these are usually an anti-diabetic agent. However, some studies came out and they showed benefit in heart failure management even if the patient doesn't have diabetes. However, like all medications, S-GLUT2 inhibitors do have some contraindications. And so it's very important to be aware of those. Some of the really important ones are patients with type 1 diabetes and patients who have prior episodes of diabetic ketoacidosis, or DKA. Those are going to be 2 really big contraindications for patients to receive S-GLUT2 inhibitors. Now, getting close to the end here, the last slide really covered our first line treatments, but sometimes the first line isn't enough. So the next 5 steps are things to consider if first line therapy fails, or again, if it's not enough. So step 1, again, optimize that first line therapy for side effect management or anything else. Typically, people will get maxed out on doses of first line therapies before you move on to any of these. Now, step 2, if a patient is unable to take or they're not responding to that ANRI ACE inhibitor or ARB combination drug, our next step is to consider replacing that or augmenting that with a combination of the isosorbitide dinitrate plus hydralazine, often called Bidel. I'm just going to call that Bidel from now on. This combination has been shown to improve outcomes in certain subsets of patients, especially those of African American descent or African descent. So that's step 1. Step 2, Now, step 3. These are going to be really advanced therapeutic interventions. So when a patient's ejection fraction drops below 35%, it's kind of the magic number, it's time to consider these interventions. So you can consider an ICD, the implantable cardioverter defibrillator. So this device can detect life-threatening arrhythmias and deliver a shock, try and restore a normal rhythm. You can also consider an LVAD, which is a left ventricular assist device. So it's a mechanical pump implanted into a patient to help the heart pump blood. And so essentially it's just pumping blood for the heart. It's often going to bridge patients from severe heart failure to a destination therapy such as a transplant. And then the last thing here is going to be the heart transplant itself, which is the ultimate intervention for anyone in end-stage heart failure when everything else has failed. And so moving forward, step 4, we can consider some of these adjunct medications. They're not really used that common. I believe a lot of them, especially digoxin, is really just used as symptomatic management, and again, not really used that often. Just something for you to read up on, especially the side effects of digoxin toxicity and how to treat that. And then lastly, step 5, you can consider inotropes. So inotropes are very, very powerful medications, again, that are going to increase the heart's contraction force. But typically these are used very short term. They are sometimes considered for patients who are on palliative care for their end-stage heart failure. And so you're just really helping to manage symptoms at that point, trying to make the patient comfortable. Again, this is not a very long-term therapy, but it is sort of a last line for patient comfort and for treating the patient's symptoms. You should be really judicious with using these. All right, finally, let's just discuss a few other considerations. Remember, 1, you're going to want to manage risk factors. Help your patient have an active lifestyle. Help them try and lose weight first. Manage that blood pressure, manage the diabetes, things of that nature. Manage all those modifiable risk factors. And then number 2, consider treating the underlying etiology. So specifically ischemic etiology, make sure your patient is on aspirin, on statins, on those things that they should be on if they have coronary artery disease, if they have ischemic heart disease. Make sure you are managing that alongside their heart failure. So those are just 2 other considerations, things to remember whenever you're treating a patient with heart failure, things to think about. And then always try and remember differential diagnosis. Again, these patients often come in with acute exacerbations of their heart failure to the emergency department, and so they're going to be short of breath 9 times out of 10. So really, shortness of breath is its own very broad, specific differential diagnosis with a lot of benign, a lot of life-threatening things. And so think about your differential diagnosis for shortness of breath, but don't discount your differential diagnosis for chest pain. There should be a video up that you can find for a differential diagnosis and approach to the undifferentiated patient with chest pain. And in that video, we use the PET-MAC mnemonic to help us remember a lot of those etiologies for chest pain. So consider all of those as well in these patients who present with acute exacerbations and have maybe some chest pain with their shortness of breath, but really consider shortness of breath as its own separate set of differential diagnoses that you're running through whenever these patients appear in your clinical practice, whether that's in the emergency room or if they haven't been doing so hot and they're seeing you out in a family med clinic or anywhere else. So these are just some things listed here to help you remember a differential diagnosis, things to think about other than the acute exacerbation of heart failure. All right, that's it for this lecture. Again, please remember to like, comment, subscribe, drop us some feedback. That way we can continue to improve and to provide some free medical education resources for students all across the globe. Thanks so much for tuning in and sticking with us.